my family stuff scheduling and board activities.
Okay.
The only thing that I may, I'm pretty sure I'll be available on Thursday at 3. I'll be driving back from Bellevue that day, but we're going to be getting, I think,
Okay.
an early start.
Okay,
So
no worries.
I'll get
Appreciate
in
it.
touch with you if there's any problems.
Okay, great. Thank you.
I have it that it is 1:31. Glenn, do we have the other IWG members on board? I see Robert.
Just
Kimberly.
Oh, maybe you left.
Hi.
Hi,
No,
I'm here.
great. Hi there. Great, super. And is it just the three of?
Well, there's Sean
for board members?
too.
Okay. I knew that Sean was going to rejoin, but I didn't know when.
I think Sean is on. So
Here I am.
Great.
Hello.
Great. All right. Thanks, Sean. Okay, so I didn't hear that last voice. So I think we can call the meeting. There's some background. I'm going to call the meeting to order for the April 30th, 2024 Innovation Work Group meeting. We are meeting virtually and welcome all. The agenda is in front of you, and we basically are going to be spending all of our time talking about the behavioral health proposed network standards and their the development of performance guarantees for those standards. The first order of business, however, is to approve the March 19th, 2024 meeting notes. Any comments or questions or issues? Otherwise, I'll accept a motion to approve.
I move to approve the minutes as written.
This is Kimberly.
you.
I'll second that.
Thank you. All in favor, say aye. Aye.
Aye.
Aye.
And I don't think there's any opposition. So minutes have been approved. Onward, the main issue as is, and this was from our last meeting, was the thought we needed to have more discussion if we were going to be moving forward with performance guarantees for the 25 contract year. So we asked at our last meeting for OEBB-PEBB staff to meet with the carriers and and we came up with this meeting. Christy, are you going to be leading us through this?
I am.
Wonderful. So you are on.
All right. Thank you. Thanks, everybody. As Tom said, our last meeting, we did also discuss these network access standards. Since that time, we have met with staff. We've had dialogue through email back and forth with the carriers. And today what we're going to do is go through, again, first I'm going to start with the overall standards, like what we see out in the marketplace, what's currently in Oregon Medicaid and also federal Medicaid. So we can just kind of, again, revisit that and look at all of those standards. We then are going to kind of go through what the carriers responded. We have details in here for each of the standards from the carriers, but I also will, as we go through that, share as we had multiple kind of email backs and forths, kind of where we stand right now. And then lastly, we'll get to those proposed performance guarantees and what those standards look like. And we have kind of a timeline as well, and then talk about next steps. So first I'll just dive into, and I know as we've talked before, right, this project really aligns with IWG goals, you know, making performance guarantees more meaningful. I think I've heard, you know, prior to me being involved here, that network access standards for behavioral health care has been talked about for many, many years. And so we've really come to the place where now we do have some best practices in place and some very recent changes to federal Medicaid rules as well that we can really rely on order to establish these standards. Again, it's been a partnership with the carriers, you know, asking and getting their feedback. And you'll see today too, and when we go to the final kind of proposed standards, that a lot of carriers' feedback and insights have been taken into consideration in those standards. So great, let's move forward. I guess I'll just pause. Any questions, concerns right now if I'm not covering something that is important to cover in somebody's mind? Okay, wonderful. Let's move forward to the next. Great. So as I said, first I'm going to just I'm going to lay the landscape of what's out there for standards. And so first in talking about appointment wait time standards, there are a couple here, and you can see one of the feedback from last meeting, right, was to really be clear about where the source of the standard is coming from. So we tried to lay that out really clearly. So providers and panel accepting new patients, the standard is a 75% goal, and that's within our industry standard in our commercial book of business. And then we're seeing also urgent appointment standards, emergent appointment standards, and then routine appointments. A couple things I'll just point out with that, an emergent appointment availability. We recognize that, you know, oftentimes this is an urgent care or an emergency department. And so you'll see that eventually has not made it to the proposed standards. And then the routine appointment in-person standards here, you can see here, there are different standards out there. So within 7 days is the Oregon Medicaid, within 10 business days is the new 2024 federal Medicaid ruling. And then having that follow-up appointments available within 14 days is another industry standard that we see pretty commonly. One thing here I just want to talk about to also kind of lay the stage is about the secret shopper survey. That is really the most accurate and meaningful way to capture these appointment wait time standards. It was just, I think, last week finalized in the federal Medicaid managed care rule that secret shopper surveys are required for the states. And really what this is it's an access survey. It's done of all, you know, it's basically using the denominators, all the provider that are in the network, and then just making a call, again, kind of pretending to be a patient, right? Looking for an urgent appointment or looking for a routine appointment, and even finding out if this provider is accepting new patients. So it needs to be done. I was just reading through the most recent kind of ruling. There's a lot of guidelines, and the federal Medicaid really also was wanting to make it be workable for the states in order to report it. So while there's guidelines of ways to make sure that the secret shopper survey is done in a meaningful way, there's not these very, very specific ways that it has to be done. So there'll be more discussion, I think, as we get closer to that reporting piece of diving into exactly what does the secret shopper survey look like. Because there's lots of different ones out there and different organizations that are providing those surveys.
Yeah, Christy, I've been thinking about this over the last week or so, and when we talk about industry standard, actually, I'm going to go back. When we talk about clinical measures, clinical quality measures, we've fallen onto HEDIS. because there is a very clear there's a very clear um, procedure, protocols. I'm blanking on the word that that describes the way that one would do this measurement. So when we say industry standard, I don't know how that translates. The other thing that happened at OEB board is that, and I assume PEB board has dealt with the same, is what we did with dental standards. There wasn't any national standards and definitions that allowed for these, and we basically had the carriers come up and create the ones that they're going to agree upon to measure and to reach. So how when we say industry standard, is there a defined protocol with how it is measured and the like? What are your thoughts on that?
So I kind of have two thoughts. So HEDIS measures obviously are super important, and they're part of that quality outcomes, really, right? And they're more follow up after hospitalization, in that IET, I think it's initiating engagement and treatment for substance use disorder. So they're measuring other things than appointment wait time and getting somebody into care. So they're just as important, but just kind of a different set of measurements that I would say are more kind of that clinical quality outcome. For these types of things, as far as access standards, these are more industry standards is really from our kind of Mercer book of business of what we are seeing large carriers across the US offering to our clients, and that navigating through how do we have appointment standards in place, and how do we have time and distance standards, and they're in place a lot with many of our clients, with large national carriers, local carriers as well. So that's really where we've pulled those industry standards, is from our Mercer book of business.
And to add, Tom, to Christy's point, Christy and Mercer have seen versions of Secret Shoppers, and these standards that are industry standards are basically the same that were provided in the Secret Shopper analysis. So in terms of what some commercial health plans are doing to like verify access, the ones in pink are kind of very in line with what they're doing already.
So basically the process that we're looking at for these standards all relate to the Secret Shopper survey process.
In many ways, yes. I mean, I think you can set standards. It's the standards, in terms of some of these goals, I think they are goals that we've seen, with other clients. It's goals that we've seen with the Secret Shopper, and we've kind of like looked at those and decided, for OEB and PEB, where do we want to potentially set them, and these are in line with those. Some we've seen 80% versus 90%, 75% versus 80%, those sorts of things, but they are in that general vicinity.
Yeah. But the way that you get to it is by the Secret Shopper survey.
That's probably the best way of doing it. That way you can it's not going to be necessarily a snapshot, but they will call those providers. And once you call the providers, you get information on whether they respond or not, and then whether you can get those access points or not. And that's the survey. So it becomes, it's going to be randomized. So there's going to be thousands of providers, and you're not going to call every single one of them, but you want to get a big enough sample so generally this can extrapolate to what your overall network's like.
And in terms of the kind of what we're, if there's standardization that's happening with this, do you think it's going to be built around the federal Medicaid managed care rule?
Probably, because it is going to be a rule that's going to apply to pretty much most, of the health plans out there. I mean, Medicaid's huge. And they have the standard out there. They have they have the rules written out.
Yeah, all three of the OEBB-PEBB health plans are part of Medicaid. So, and when does the rule become operative? Is it something that's in place now? Is it something that they're working on the logistics of it or the methodology, or is it pretty much in place? Is it going to be around in 2025? Because as we get farther down the process here, the issue is going to be, do we have, if we're requiring the plans to do this in 2025, but the methodology isn't worked out yet, that's a problem.
I do think they've provided a time period from the time of the effective final rule for when the reporting needs to be done.
Great.
And it's not, it's not 2025, which also kind of has informed, I would say, our proposed approach as
Got
well.
it. I'm sorry for I might be jumping ahead
No.
because, I've read ahead and things like this, but this, the analogy of, when we're doing something different and very important, one, we want to do it right. It has to be doable. And if it is something that is being done not just for OEB and PEB, but it's going to be, kind of health plan wide for our three carriers, we need to make sure that we're in gear with all the other work that's being required of them, because there's this whole thing around the burden that, that is real.
Agreed.
Okay, let's continue on.
Okay.
Unless any committee has any other comment or question. Yeah, let's continue on.
Great. All right. Next slide. Okay, so then continuing on just with the appointment wait time standards, the first two here that are listed, so routine appointment and the medication management appointment. So these are specifically for virtual appointments that are maybe with like a third-party provider that is in place. And so just again, wanting to make sure that there are using industry standards when contracting with a third-party provider to provide virtual appointments and virtual services. And so 3 days, and this is one area I know we've had some feedback as far as its average time to first available appointment. And then it should be, and then its average time to first available appointment for medication management is 5 days. So that's one of the adjustments that we made in our final. And then just to share, the specialty populations down here is part of the Oregon Medicaid. And then again, this is talking about, right, that admission to residential care assessment and entry for different specialty populations. Moving on to the next slide. Okay, so talking about time and distance standards. So I have we have two different slides here. So one thing that we have found in our conversations with carriers and looking at different standards is there's different measurements for time and distance. And so this first one is using the large urban, rural, and then the CEAC designations, and showing here these are Oregon Medicaid, and then the time and distance to the psychologists, ABA providers, and other kind of intermediate intensive outpatient program facilities. That was not specifically called out by those provider types or facilities in the Oregon Medicaid, but we do have some industry standards there, which is the same as above. If we move to the next slide, you can see there's additional time and distance standards. And this is from the federal Medicare standards. And this is the standards that most of the carriers recommended using. It's more of the county designations, and again, it goes to that large metro, micro, rural, and then the CEAC. And I'm sorry, I usually have that off the top of my head, but that is like, you know, considerable access considerations, or counties with extreme access considerations, a CEAC. And so, again, just recognizing that there are different standards out there, and really the goal was for us to not ask the carriers to report on a completely different set of standards if there's ones that they're using right now that make sense. And so that has been our goal, and we've incorporated these updated standards. One other thing I just wanted to call out here is for the federal Medicare standards is that there is a telehealth credit. So when they're talking about, and I'm how many providers, if the providers in the network meet these access standards, you can't use telehealth providers to meet those standards, but there is a telehealth credit that is given for percentage of members that reside within the required time and distance if there's telehealth providers in those areas. So just it's an interesting approach that federal Medicare standards took to accommodate having also telehealth providers in your network. How do you give credit for that? Any questions on these two time and distance standard slides?
Just to confirm, these are ones that that our 3 plans are already dealing with.
I'm not sure if I can definitively say that all 3 plans confirmed. I think 2 out of the 3 for sure confirmed that these were the desired time and distance standards.
Okay.
Yeah.
All right.
Okay, let's move to the next slide. Okay, so then talking about provider network diversity, you know, the different types of standards we see out there is, first of all, you know, and we know this is self-reported information, you know, and having that race, ethnicity, languages spoken, language access and interpreter services available, office accessibility, whether it's ADA compliant, and then clinical specialty. I think I shared previously, we have heard within the industry that, you know, providers aren't necessarily sharing, you know, sexual orientation and gender identity, but they are sharing these other components of demographics and their diversity. And then clinical specialty, though, is where that important component comes in, is if they have that specialty in servicing a, you know, a special population and their you know, individual needs. And then we also have on here the Oregon Medicaid, Federal Medicaid Managed Care Rule for provider diversity. And it's just saying that the directories must document the provider's cultural and linguistic capabilities and whether the office facility has accommodations for people with physical disabilities, including offices, exam rooms, and equipment. So again, pulling on these standards as we make our proposed ones that I'll get to here shortly. All right, moving to the next slide. All right, so here, and I'm not going to read through all of these, but we just wanted to be able to share, you know, kind of in our original standards we shared with the plans. Tell us what you can report on right now, what you can't, what is partially reported. Do you have an alternative reporting or metric that you'd like to do? You know, so just really gathering this information so that we could land on, you know, the best proposed standards to move forward. And so, yeah, I'm not, as I said, I don't think I'm going to read through all these, but you can kind of see that all the plans are kind of at different places for what they can report on. Rose, if we move to the next slide, it just, again, this kind of goes through, these are the appointment wait time standards. These were with the virtual third-party vendors, that last one there. If we move to the next page as well, I think this is where the time and distance standards actually, let's do one more, sorry. All right, so then the time and distance standards, this is where we got the feedback again about those county designations aligning with CMS, with those adequacy requirements. So just seeing that this is how we went about this process and bringing in the carrier's responses back to us. Again, so we're not asking for a completely separate set of standards to be reported on. Moving to the next slide. And then here's that provider network diversity. And again, we recognize that this is self-report. You can't, make a provider at this time report this information, but there are definitely some standards out there that we can move forward with. All right, next slide. All right, so now we get into the fun stuff of our proposed behavioral health network standards. So I will go through each one of these so you can kind of see the changes that we've made and how we've incorporated feedback and discussions I know Tom and Kimberly we've had with you previously. And so for the appointment wait time standards, we have that providers and panel accepting new patients, that's 75% goal. We have the urgent appointments available in 48 hours. That's an area we aligned more with some of those federal standards of the 48 hours. And then we also have routine appointments available within 10 business days. Again, both of those, the 48 hours for urgent, the 10 business days were for routine, were also ones that the carriers gave us feedback on. And for those three there, 2025, and pretty much for all of 2025, you can see that that is report only, setting a baseline. But again, having these 5% fees at risk being in place in 2025 for those reports. The next, I'm going to go to that darker pink, the next.
Can we stop for just a minute?
Of course.
I've been thinking about the first one, and the context that I was thinking with it was I was the medical director for primary care with Kaiser Permanente when we ended up moving to get all of our population onto primary care physicians panels. And the question was, what is the right percentage of providers in the medical office that should have open panels? And the number in that type of established system was always enough to be able to give a pretty wide range of diversity of provider, young, old, male, female. Those were the parameters that we were looking at then. And the number that we came up with was if we hit, again, in a closed system, if we had 50% of our primary care providers who had open panels, taking on new patients, and then also follow to make sure that, yes, people within, with urgent needs could be seen within, 48 hours, and routine within 2 days or 2 weeks. That met our goal. So my concern is that while that 75% goal is probably appropriate in a PPO environment, it may not be the right number as we become more health system focused for these delivery plans. And obviously Kaiser is a closed system, but I would guess that as we have consolidation throughout the industry where behavioral health therapists and the like are banding together into entities, they also would be responsible. Let's say you have a group of 15 therapists. Is it appropriate? Do you need to have 11 of them always be open? Or what you need to do is maybe even have 5 or 6 but that they still meet the urgent and the routine availability standards. That was just, I think that that goal is not is reflective of a different environment than what we're seeing, at least in some places in Oregon.
So Tom, I'm not sure if I've seen behavioral health providers like uniting in that way. I've kind of seen them
And it may
actually
be
going out
only a
into,
Kaiser Permanente thing, but
well,
my guess
Kaiser
is
also
it-
contracts outside of Kaiser. They also have commercial
Yeah.
behavioral health providers.
I know
And
that,
so, well, okay.
I-
I mean, if
but
Kaiser can supplement their network, they've done it. I know they've done it. They've talked about doing it. So I don't think it's necessarily it's going to be just all.
Emery, I disagree with you completely. I would guess that if you looked at the behavioral health program at OHSU,
So
where
we
they
actually
have a
looked at the
department.
data for Kaiser. We looked at the data for Kaiser, and there are hundreds of providers that are in the Kaiser system or in the Kaiser network that OEB and PEB members used that were also in MODA and Providence.
I understand.
Hundreds,
And,
hundreds.
and what's
So it's
the,
not
is
all
it,
just
what's,
the self-contained
did
system
they
for Kaiser.
did they represent in terms of the total number of Kaiser patients who are being seen? 50% of them? Was it only 10%? I'm just trying to.
No, there were more. There were definitely
Wait a minute. Wait a minute.
You're asking a question whether it's 10%. If you want me to give you a number, I can give you the number.
I'm just trying to give you context. The context that I've dealt with was one of what I saw in primary care. So,
and I'm giving you the exact numbers from behavioral health.
Okay.
Behavioral health and primary care are different. Yes, primary care for Kaiser, self-contained. Behavioral health is not self-contained. There are other networks. And for behavioral health for Medicaid, Kaiser subcontracts that completely out.
Okay. And Medicaid represents 10% of Kaiser's population, maybe 15 max.
I don't know. I mean, they're part of organizations in Tri-County, and Tri-County is the biggest.
I understand. My understanding is that it's in the 5 to 10% of their population. Of our, so I understand that there's. I'm just trying to, what I'm trying to do is we're going to set a goal, and if it's going to be a standard that we're going to hold people to, does it make sense in all the ways in which our health plans are providing service?
You know, Tom, one thing I did a little bit deeper dive into this as well, and I just, one thing I found, and again, I'm hearing you say that Kaiser doesn't have, they have a smaller percentage of their population that's Medicare, Medicaid, but according to the CMS network adequacy standards, they do explicitly state that regardless of whether it's an integrated delivery model or has exclusive contracts with providers, they still needed to meet all of the network adequacy standards. So that's kind of like that's another, so that's a federal CMS guidelines, call out specifically in this regard, that kind of informed going this direction, because the concern, I think, in a way, is if we lower that standard as well, is that there could be then huge gaps of areas that have no providers with appointment availability, and there's not a way to really, if we lower it too much, then we're kind of not having it be a meaningful standard.
Yes, the issue of having availability throughout the state, both for urgent and routine, is the key. No question. what I'm questioning is whether or not, and we see that, I'm looking at the source for those second two, and Oregon Medicaid and the federal Medicaid managed care rule. I understand that. For the the only thing I'm pushing back on, and I might be wrong here, is that I wonder about that 75% goal in every setting. And if you're saying that Kaiser's already meeting it, but I'm not trying to limit it to, Kaiser. I'm trying to discuss this in the concept of, if there are, I'm not sure how meaningful it is. That's all. And I'll, if I'm the only IWG member who has a concern in that way, it's also my last meeting, so you can just ignore it and move on. But I just want to make sure that is a meaningful goal. That's what I'm trying to get at. And when it says industry standard, my guess is that it was built around again, a PPO type of environment. And all I'm saying is, do we have other elements in the state of Oregon where, let's say, they're below 75%, but they're meeting the urgent and routine needs of the people that they're responsible for? Because if they are, they've done what I think is the meaningful part. Let's move on. I'm not trying to derail things.
I do think that, I guess I just have one more. I do believe that there is also within kind of the secret shopper is that having the providers that are accepting new patients in the directory be represented of what's true, to a point, right? I know it's not updated in real time, but there is a piece of that if somebody's trying to find behavioral health care and you call 10 providers and none of them are accepting new patients, you tend to drop out and not get the care.
I agree. And so that being able to answer that question is the key question. And if you called a behavioral health entity that had nine therapists and 3 of them are able to see you tomorrow, from my view, that's success. And yet it would look like it had the potential of looking like, well, they're only accepting, only 33% of them are accepting new patients. And yet you have 3 people who are able to see those patients immediately and in a routine way, and that's success.
In that scenario, no, I agree. But also I think about in a rural area where there's 10 individual providers and,
and that's all I'm saying is that is there ever a way to come up with a standard that addresses those 2 different issues? I don't know. I don't know if one size fits all in this, is what I'm trying to say.
Yeah, I appreciate that comment.
Okay, let's move on.
I guess. Okay. All right, so if I go down further to the darker pink ones, those are, again, those virtual access times. We changed those so they're average time to first available appointment, 3 days virtual for a routine, for first available, and then 5 days for medication management. Again, report only in 2025. Going down to the blue then, the time and distance standards, again, aligning to those CMS county designations of large metro, micro, rural, and CEAC. Again, that's the federal Medicare standards. And again, 2025 is just report only. The provider network diversity. So this is that self-reported race, ethnicity, language, to include clinical specialties. And I'll just say we recognize this is a more squishy standard because there isn't necessarily an industry standard that says what percentage of your provider network should be diverse. But it's something that we are seeing in the industry more measurement of this and having some goals in place to improve. And so that's where, you know, for 2025, having report only as a baseline. And then you'll see in 2026 that we have more of, you know, some type of target or improvement goals. The last provider network directory piece here is the purple. So having the directories reflect the provider's cultural, linguistic capabilities, office accessibility, and self-reported race, ethnicity, language. Again, that's an industry standard. I actually think it is in this new federal CMS, as I'm reading through it, that having those directories up to date is also an important component. And then the last standard we have on here is just for 2025, and it's having an improvement plan. And so having the plans create an action plan to address at least one of the areas of deficiency from the 2025 reports. So that's 2025. I'm going to go then here to the last column on the right, which would be 2026. Again, right now we have the proposed fees at risk. Some of them are for meeting goals, and some of them are also, again, continue to be report only. The ones that we had, I guess, as far as fees at risk, we had for the providers and panel accepting new patients. We had the reporting of the urgent and routine times to be reporting. We had fees at risk for not meeting the virtual standards for having a partner in place. I think currently the carriers that have partners in place did say that they could report out on this and they are meeting these metrics. Time and distance standards, these are really the ones I would say that are really pretty solid. They're solid as far as having standards in place and having the carriers say that they can report on it. So that has a fees at risk for not meeting the standard. The provider network diversity, the first one is fees at risk for, you know, if not meeting some target or the improvement goal. And then the network directory is having fees at risk for the information not reported in directories. And then obviously the last one, the improvement plan, doesn't take place in 2026. That's a 2025 one. So I'll pause and see if there's questions, comments.
Yeah, this is Sean. I think every time having this discussion, I think I ask the same question, but I'll keep asking. On the time distance standards, the way that I understand that metric works is your time distance check mark, so to speak, you know, of you have someone within some blank distance. It doesn't specify whether that person is taking patients. It just specifies that there is someone there technically. So I've always felt that that's, of all the metrics, that one's sort of the least helpful, because it's like technically there could be a person that just is never available because they're in a rural area, but technically they're there, and so they get a check mark, you know. Is that right? Is it my understanding correct? Versus like there's a time distance between a provider that's actually open.
Your interpretation is correct. It does not take into account if that provider is actually taking patients, which we tried to combine those two to have the time and distance standards include providers that are accepting new patients.
Yeah, I understand. Like it's more of a national problem. It's like that's a Medicare like, that's an industry-wide problem. And sometimes there's little opportunities for us to solve things, but that one feels like a big one. But I just, as far as, that's the one that I probably hang my hat on least. And if I was choosing between fees at risk and, that probably would not be my top choice just for that reason, because it's kind of like, I mean, it has a base level use, which is that they have to have somebody, within some amount of distance or whatever. And it's like, well, okay. But it really could be this one person that like 5 different plans are all relying on to be the person that's getting the check mark for them. So anyway, that's all. Nothing particularly to solve, I guess, per se, but I just wanted to be clear.
Well, and I think that's why that one in some ways is the most readily used, is because it's the easiest to report on.
Right. Exactly.
But unfortunately, as you've pointed out, and I think what you're saying, though, what I'm hearing is that it speaks to the importance of having multiple metrics in place, right? We can't just do one. You have to have multiple metrics in place in order to really kind of put the puzzle together of what's really happening from that member's experience of getting care.
Yeah, exactly. For the future, maybe just whenever y'all are in national conversations or whatever, maybe you can like remember my pet project. But it feels like what this is really trying to do here, this one, like we're not really concerned with urban area. That is not what this is for. This is really about rural access. That's what this is. And so what it seems to me that there should be a metric that's actually just rural access. That's what it is. And you would design it totally differently. It would have something to do with yes, there would be distance, but it would have more to do with, access. And so I would just advocate in the future to whoever's listening, that there's just a rural access metric, and that's that. That because that's I think what we're really getting at. Yeah.
So Sean,
Mhm.
to your point, we actually in an earlier version we did have a accepting new patients tie to that, but we got considerable pushback.
I'm sure you
from
did.
lots of places, and so it got removed.
Cool. Well, thanks for thanks for trying.
Still trying.
I find it fascinating that the proposal for 2026 is that what I think is the less meaningful appointment wait standards is the one where fees are at risk, and the ones that are meaningful, urgent availability and routine appointment availability, are still reporting only. I mean, I think it's if you ask me, those should be reversed, because I think what matters is whether or not our members are getting appointments and getting seen for both urgent and routine, and whether or not the panel is at 75 or 74 or 63 is only gets at the part that Sean just talked about in regards to, do we have deserts, where there isn't availability for our membership.
Has other comments from anybody? I don't know if I want to open up this. Do we want to change those up on 2026 as far as fees at risk? I mean, I'm hearing you, Tom, and so I
think that what we do, my recommendation would be that we accept the 2025 recommendations, and we include what you have written down for 2026, but that those are, we look at them, and the IWG in spring of, and I think Margaret before had talked about having the reports back in 2020 in May, and having IWG look at this again and say, well, this may be the right set for 2026. But I think she said that if by 2020, by May, it would give time for both OEBB and PEBB to go ahead and do the negotiation. Because if it turns out that we're whack in one of these, then it needs to be thought through again or something.
Yeah.
Or what we do is we, as we did with the dental plans for their performance guarantees, we set individual, improvement platforms for each of the plans. Again, I think that my recommendation of how to move forward with this is not to decide on 2026 when we don't even know whether or not the plans are going to be able to come up with the secret shopper methodology and have reliable data and things like that. It's just too early.
Yeah, that kind of informs, I think, our next slide, Tom. So I think if we move to that, it just kind of shows, I think this is what, we talked about with Margaret, of kind of how this timeline lays out. So the 2024 right now agreeing on, some sense, I'd say some format and really what are those standards. And then as we look into 2025, looking at that reporting for baseline would be due May 1st. As you said, Tom, that seems Margaret felt that gave enough time for PEBB and OEBB each to have this. And then that would also then allow us to have setting those targets for those incremental improvements for goals. And then also gives the carriers time to develop and submit their plan for one area of deficiency. And then in 2026, yes, then once we have that information, being able to, I think, get more into the details of what each of those standards are, where does it make sense? Maybe you're right, the baseline reports shows certain gaps in different areas that make more sense to put fees at risk versus what we're thinking right now. And so then being able to revisit that.
So go ahead, Glenn. You actually raised your hand.
No, I was just going to say, I think the issue, I think this is important to keep in mind, is that in 2026, we set incremental goals. So it's not that the fees at risk would automatically go into place, in 2026 if if you don't meet the 75%. So I think it's very important to keep it in mind based on their, the baseline that we achieve in 2025 for the carriers. We'll then sit down and really set, incremental targets for improvement. I just want to make sure I got that correct, but it just seemed like
That's not what's written down, but I am 100% behind that approach, Glenn.
Let me just ask, is that what's being proposed here, Christy?
Well, I think our approach was that for some of those basic ones that have been pretty much industry standards, again, like that CMS, Medicare, time and distance, that even though I know it's not as meaningful because it doesn't include those who are accepting patients, but that one would actually be fees at risk because it is it's a very standard network time and distance requirement. So some of them that made more sense, again, that's what we're proposing. But you know, I do think there could be some data that comes from the baseline reporting that we might be, you know, it might make sense to have fees at risk be somewhere else for a goal. You know, and I think some of those that are stickier, again, like the provider diversity, there isn't a standard out there that says this percentage of your, you know,
Gotcha.
network needs to be diverse. So that one I feel like has to be an incremental goal or target. So I think each
okay.
standard might have its, you know.
Okay, well, I wasn't proposing that we did, you know, I was just, I guess I misunderstood from reading this. So sorry about that.
No, I don't think, I mean, if we go, sorry, Rose, if we go back to the last slide, there is some of those we have said, you know, some of them have report only again, some of them are, you know, again, if you're not meeting the standards. And then there's the diversity one is the target improvement goal not met. But what I'm hearing you say, Tom, is having, sorry, my dog is making noise. So trying to have those, I'm sorry, we have an, an ambulance going by and my dog is.
we like dogs. Dogs are good.
She's howling. But we'd like to, I'm hearing you say that setting 2026 in stone right now doesn't make sense. It makes sense to set 2025.
That would be
and
my
maybe we can okay.
That would be my recommendation to this group, and it would be subsequent recommendations to, that would be the recommendation that I would make to the OEBB board, would be us setting 2025 and then revisiting when we have made sure that we've gotten everything in place. We understand what the baseline is, and then to have something that's reasonable. People's opinion. That's I'd like to hear other IWG members' views on the idea of us, you know, essentially approving the 2025 standards as we've outlined here, and their reporting response requirements for the plans, and then but holding you know, the group having to reconvene in sometime in 2025 to confirm what the 2026 standards should be.
This is Kimberly, and I do agree that we need a little bit more. I think that getting the information this next, I think, didn't Margaret say like by May we would know the reports would be gathered? And I think then that way we can really look at it and make further decisions. I always get a chuckle out of Sean is so spot on with his, and of course it's easy, the time distance standard, that's easy to do the 1% fees at risk because everybody's kind of used to that and it's easy to meet. It doesn't mean whether or not somebody got mental health care. So I think we need more information. I think that we can agree that 2025 looks good. And if I need to make a motion, I can make a motion. And then I love the idea of once we get more information, we deep dive as much as we can and really solidify our plans for 2026.
This Robert, I agree. I like the two-step approach on that. I also, you know, the framework, the general framework, I like. Even at this point, I think these standards are measurable, so we can take a look at what's reported and fine tune a year from now. So I like the direction.
Sean.
Yeah, I agree. That makes sense. I can get behind that. I would add a suggestion. Thinking about 2026 for us. And this is the challenging part when you get down to metrics and you start putting fees at risk. You know, people, when money's at risk, people want to get super literal, and they're like, what exactly do I need to do in order to meet the exact thing? And sometimes the risk of that is that we end up sort of teaching the system to be the opposite of creative, right? Because what they're doing is they're gonna do the exact thing that we're doing, we're talking about. So you got to be, you know, you got to be careful about exactly what you're asking, because you can get, you can end up accidentally making things like more rigid than what you meant, just so that because they're focused on one thing. So with that in mind, I'm not actually suggesting some kind of new metric, but I want to like just kind of nudge you to think about something. And how do we encourage the system? And Oregon has some precedents for this. How do you encourage this system in Oregon to be more creative? Yeah, that's a very difficult thing to put in a metric, but we mentioned last time, what we're doing right here is we're pushing the system to solve the problem in one particular way. What we're basically pushing them to do is to have more providers. That's the bottom. That's kind of when you sort of read between like what is happening here, what are all these metrics? The answer is you just have more of them, and like that's how you win. And so then the system is going to push back on that because, you know, first of all, there's very few of them. They're all poaching from each other essentially at this point. There's a pipeline problem. You know, there's a diversity problem related to the pipeline and so on. So that's like one solution that has its own set of problems, which is there's just not enough of them. And we're basically pushing up against the system to be like, hey, you don't have enough. And they're like, yeah, I know. And so this is where the rubber meets the road. So we talked last time of talk therapy is a very important, necessary, critical component of behavioral health. Period. Like full stop. And there are other alternatives. Somatic, you know, technique, you know, this sort of thing that are sort of in addition or adjacent to talk therapy. And we're not really, a lot of these metrics are not sort of encouraging that kind of thinking, like, you know, like if we're basically attacking the waiting line essentially, to get into talk therapy, like, is there a system, is anyone being creative about approaching that waiting line and being like, hey, have you tried this while you wait? While you're waiting for this talk therapist, have you tried this thing? Let us connect you. Just try it out. You know, that sort of thing. In other words, increasing the size of the pipe.
Yeah.
Rather than trying to force more things through the pipe. So just
Sean, what you're,
think about.
yeah, what you are, once again, I'm going to vote with Kimberly. You're identifying the keys. We have not, in any of these, we are not dealing with outcome. In other words, did the intervention make a difference in the person's life? Now, there are elements. I think our plans are trying to look at that and come up with ways of looking at least the people that they are interacting with are getting better And I've heard in OEB, both our two carriers have come up with, are trying to come up with ways to look at that. And that's the, you know, that's what we need. I know that MODA had been looking at actually doing some with their network. They're trying to come up with ways to measure, you know, what percentage of people got better with the talk therapy. So, you know, it's like the somatic component of it was, okay, you're treating someone for pneumonia. How many survive versus how many die? You know, there's a, so what I would recommend that, again, I get to pontificate as I dribble off the court, is to have the um, our OHA staff with consultants and with our carriers start trying to advance the conversation, so it's not like how many people are getting in the door, to people are getting better. And again, our plans are already starting to do that. So let's work with them in their own internal evolution of improvement, so that we start getting at what really matters, because both are critical. They have to get in the door, and then the therapy that that people are getting has to be effective. And and if we can measure that, that would be great.
I have a couple things, if I can add to that, Tom, is that I think what you're describing is, I mean, that is the ideal, and we are seeing that in these networks that are able to employ or have all of their providers on the same electronic health record, right? And they're doing
Platform,
clinically
right,
valid,
right.
right? They're doing clinically validated
Yes.
assessments. They are, you know, they're offering continuing education to their providers. They actually are rating their providers and how are they doing and what are the outcomes. But it is much more complicated, obviously, in these contracted large networks to get that data. But it is happening. I think there is that recognition that we have to have. And I think that's what HEDIS is also trying to measure, right? When we do measure that, it's just not part of this 5% that we're looking at for these standards, but there are those HEDIS measures that sort of get at that. I don't know if they're not really measuring outcome.
Well, yeah, and we're coming up to the end. Is there, in terms of additional slides, are there things that we need? I think we had consensus. Kimberly, you said you'd offer a motion. I don't think we need a motion. I think there's consensus that we want to move forward with the 2025 recommendations as outlined, that the 2026 ones that we see here are guideposts, but that subsequent IWG discussions need to occur. They obviously have to be approved by each of the boards. At least that's the standard that I think we have at OEB now. And we'd love to see, as time goes on, evolution, to the point where we're starting to look at ways to measure outcome in our work with behavioral health interventions with our members.
Yeah, I totally agree. And it's, as I say, that there's a room for allowing the system to be innovative.
Yeah.
I would, and I think there's a way to accommodate that in some form of metrics, such as, for example, I'm just throwing this out, that there's a metric that's basically like they'll at least propose some kind of some innovative something. And we need to, you know, they'll present that to us, they'll show it to us, they're trying something, and that maybe that's just the metric. You know, peer support groups, meditation classes. I mean, like whatever it is, you know, they're trying something, and they're trying to innovate, and also some of this mechanical stuff that they kind of need to do. So yeah, that's good.
Got it.
Sean, I had one. one thing just to Sean, to your earlier comment as, and I'm happy to share this after the meeting, but there was a recent study that just came out that just spoke to exactly what you were talking about as far as shortage of behavioral health network. And it was actually saying that it's not really the case, that if that was the case, that we would be seeing the same out of network usage of PCPs, because there is just a much shortage of PCPs as there are behavioral health providers. So I'm happy to share that, because it's kind of it's a completely different narrative, and it's a study that just recently came out. So
Yeah, that's interesting. Yeah,
I'll share.
thanks.
So generally, I think about 20%, 15 to 20% of behavioral health usage is out of network. You know, it's like in the low single digits for like physical health. So people are getting services, they just aren't in the network in many cases.
Yeah. Awesome. Sorry, I just wanted to make sure I responded to
that's good.
your
That's
comment
good. That's
before.
good. Yeah. Christy, is there anything else that we need to do this afternoon?
I don't think I think I've gone through everything. Oh, Glenn, I see you have your hand up.
Yeah, I didn't. I just wanted to say that, I'm, pretty clear on, this kind of two-step process that the IWG has approved for the behavioral health standards. Just wanted, we've clarified that. Second thing I did want to say to all the IWG and observers, there will be no June meeting, or May meeting actually, that the IWG will be on hiatus for most of the summer. It's going to be because we are losing, Tom, and we'll be kind of doing some strategizing.
Thank you, Glenn.
Okay, so Rose, do we have any public comment?
No, Tom, no public comment.
Okay, so the only thing that I think that there still is a lot of work that needs to be done for us to be able to report these things in basically a year from now. So my hope is that OEBB-PEBB staff will continue to work with carriers and our consultants to continue to collaborate to pull together how we're going to and what we're going to be what you're going to be looking at come May of 2025. Because when we, I looked at your, I think back, Christy, to your 2 or 3 of the slides where there was not only green checks forward ahead, there was red and there was yellow. So there's still a lot of work that needs to be done. And we need to do it in the most consistent way and the, frankly, the least expensive way, because anything that measurement costs money, and we don't have much to go around at this point. So my recommendation is also to try to come up with something that is affordable for our members. I could say for the plans, but costs that the plans have get passed on to our members. So that will be very important for work that has to occur over the next 3 to 5 months. I think that comment for OEBB, we will bring this to the OEBB board probably in May. We'll discuss that later this week, but May or June, essentially authorizing us moving forward and the 2025 performance guarantees. And I assume PEBB maybe PEBB doesn't have the same process, but it's one that we have been trying to be explicit in at the OEBB board.
Yeah, it's the same process, Tom, for PEBB.
Okay, super. Okay, so with that, if there are no more comments, we are ending exactly at 2:45. You're expected on arrival. Bye all.
Tom, thank you so much for all you've done for Innovation Work
Yeah.
Group. We really do appreciate you. And,
Yeah.
you know, you just have kept us all on task. And it's so important that you just know that all of us need folks like you to keep us moving ahead and really striving for
Very
change.
kind.
So thank you, Tom.
Very kind. Thank you so much.
Yeah, thank you.
Okay, bye all.
Thank you.
Bye. Thank
Take
you.
care. Bye-bye.
Bye.